You're listening to Be Health Connected, a podcast by the St. Louis Area Business Health Coalition. Your host for today's episode is Laurel Pickering, BHC President and CEO.
Hi, I'm Laurel Pickering, President and CEO of the St. Louis Area Business Health Coalition, and welcome back to the BHC's Be Health Connected podcast. As the new leader of BHC, this is my first time as the interviewer, and I am very excited about my first guest, Dr. Marty Makary. Marty is a New York Times bestselling author, a public health researcher, and surgeon, and he is the chief of islet transplant surgery at Johns Hopkins. Marty and I have known each other many years, and he is widely known for exposing what's wrong with our healthcare system from an insider's point of view. He has been a champion of transparency in cost and quality before transparency was a thing and before so many of us were focused on it. His first book, Unaccountable, exposed serious quality issues that he observed when he was a resident. And his second book, The Price We Pay, dove into the cost and payment challenges of healthcare. And he is publishing his third book in healthcare, Blind Spots, When Healthcare Gets It Wrong and What It Means for Our Health. Marty, we are so excited to have you here. Thank you for taking the time to be featured on our podcast.
Great to see you, Laurel, and congrats on the new role. BHC is lucky to have you and such a thought leader in American healthcare. So it's cool to see you in this new job.
Oh, thank you. So I want to start by having you tell our members and our audience about your journey. It wasn't enough for you to just be a surgeon and do your thing every day. You got in there and you saw that there were some serious problems, challenges, issues that you wanted to expose. And then you have now launched a career as a best-selling author and have been such an important thought leader around the issues that we care a lot about, cost and quality. So tell us about your journey before we dive into the book and other topics.
Sure. Well, I would say it's been a atypical or non-traditional journey in medicine. But, you know, in medicine, we have a culture and we are kind of taught to put our heads down and do our job playing whack-a-mole at the end stage of chronic diseases and care. And no one's really asking the big questions of why. Why are half our nation's children suffering from obesity or overweight? Why are 1/5 of children today dealing with prediabetes or fatty liver? Why do nearly half of all children have a mental health disorder or diagnosis by the time they turn 18? So you have all these big questions. In my field of pancreas cancer, no one really asks, why has pancreas cancer doubled in the last 2 decades? Yeah. And so we get this sort of tunnel vision, and these are good people. The docs are good people. Every health professional I've ever met wants to do good. We're all united by a sense of compassion. But we've done a terrible thing to health professionals. We've put them in this on this treadmill where we've told them to bill and code and increase your volumes and drive revenue, and this is how we measure performance. And we're only playing whack-a-mole at the end stage. So when you start seeing things that just don't look right, or you observe issues that we are not talking about in medicine that we should be talking about, you want to say something or do something. And I used to tell my dad, who actually is a retired physician, when I was in school and residency and training and early in my career, I would tell him these things that just I was baffled by. It just didn't seem right. And so he told me to start writing them down, and just so I could remember them when I had the chance to teach other medical students and residents. And that really turned into the stories of the book, The Resident, which the book was called Unaccountable, and it was turned into the TV show, The Resident. And then that book was really about the quality conundrum. And then the second book was about the cost crisis in medicine, and that was called The Price We Pay. And so this new book I'm really excited about. It's called Blind Spots, and it's about medical dogma. It's about the issues in health where we're not talking about that we need to talk about.
Yeah, we're going to spend some time diving into this new book. I do want our audience to know that Marty is doing a St. Louis tour coming up at the beginning of September. He is going to be at the St. Louis Public Library on the evening of September 12th, and he will be with us for breakfast on the morning of September 13th. So if you haven't registered, make sure you do, and let your friends and family also know about the library event. So it's a great opportunity for St. Louis to learn about the book and to meet you, Marty.
I'm really excited about that, Laurel. I love St. Louis and I love spending time there. So I'm really excited to come out.
Great. I'm glad to hear you love St. Louis. I think everyone knows I'm new to St. Louis and I am learning to love it as well.
Yes.
So why don't you start by giving us a brief overview of the book and a bit of a preview for those who will be with us and are going to learn more when you're here in person.
Well, smart people in every industry can develop blind spots that can significantly affect their ability to make good decisions. And it's just intrinsic to leadership and to organizations, to the human brain, the psychology of an individual's way of thinking. A famous doctor named Leon Festinger in the 1960s described this. Really, it was essentially the founder's effect. That is, we tend to believe what we hear first. And when new information comes in that challenges those ideas, we tend subconsciously to find ways to reject it, dismiss it, or reframe it so that it fits what we already believe. Because the brain has this tendency to just hold on to our beliefs, and it's sort of intellectually lazy. And so in order to be objective, you have to actively suspend your biases, recognizing we all have biases, actively suspend those biases and consider new information and be truly objective about it. Now, in medicine, we have the same issue. We have groupthink. We have, as a result, medical dogma that can take on a life of its own, and it can create a culture within the medical establishment. Every doctor I know tries to do the right thing, every health professional, but we've got good people working in a bad system. And we've done a terrible thing to the health professionals in America. We've told them to play whack-a-mole at the end of the journey of chronic diseases, to be on this billing and coding treadmill. And what we've done in this busyness of playing whack-a-mole is we've forgotten about health, about the root causes of why people are coming in to see us, of the universality of all of these diseases, from childhood diabetes to autoimmune diseases to mental health disorders, heart disease. We have lost track of recognizing the role of food, environmental exposures, behaviors, all the things that result in people getting sick. And because we've ignored all these things, we have the sickest generation in human history and the most over-medicated generation in human history. Maybe we need to talk more about treating diabetes with cooking classes than just putting people on insulin. Maybe we need to treat more high blood pressure by talking about sleep quality and stress management, not just putting people on antihypertensives. Maybe we need to treat more back pain with ice and physical therapy, not just surgery and opioids. We've got to address food as medicine. We need to address school lunch programs, not just putting every 6-year-old on Ozempic. So there is a movement now and a burgeoning science that is saying, hey, we cannot see the forest from the trees. We've got to stop, zoom out, and talk about these underlying issues in medicine that we have not been talking about, what I call our blind spots in medicine.
Yeah. It's interesting, Marty. I didn't know that this is where you would go with the conversation. And we as a coalition have agreed 100% and have been focused on lifestyle medicine. And I learned that there's a certification physicians can get in lifestyle medicine. And we're having an event in December where we're inviting primary care physicians to come talk about how they can be better trained, better equipped to have those conversations with their patients. And I think the typical experience is probably something I experienced is I went to my PCP, had a little bit of high cholesterol. My doctor wanted to put me on a statin, and I said, oh no, I'm going to fix this with diet and exercise. And he said, great, good luck. You go do that and come back in 6 months and we'll see how you did. But no tools to offer me to help or guidance or anything. And I think my experience is not unusual. It's like, great, good luck, go do that, go try it, and then come back and see me, and
Right.
we'll see where you're at.
We have this system, right? It's eat better, exercise more. We don't even tell you what that means to eat better. When we do, we usually have it backwards. We're, demonizing fat and pushing people into low-fat diets. And that's medical dogma, speaking of groupthink, that we got perfectly backwards and still do today. And then you come back in 6 weeks with all these meds and we tell you, you're a bad, non-compliant patient. And there's this sad paternalism in medicine to essentially blame patients for their diseases, that it's the fault of the public. And sure, there are behaviors that can improve, but maybe we've been giving people the wrong information. Maybe the hardest part of managing chronic diseases is not telling people what to do, it's helping them do it. And that's what a lot of employers are doing now, and it's exciting.
Yeah. I think about, so when we think specifically about your book and some of the examples that you have, I think about in medicine, how many times have we been told something is good for you, then, oh, no, it's not good for you. Or, oh, something's not good for you, but, oh, actually, it is good for you. And, I understand that new evidence comes to light. And so I understand how that works. But I'd love to have you share some examples from your book where medicine got it wrong and sort of what we've learned from some of those examples.
Well, the worst thing you can do is exactly what you said, and that is to put something out there with such absolutism that everyone must do something when it's really just an opinion by sometimes from a small group of people at the top of the medical establishment. So when we use good scientific research, we shine as a profession. We help a lot of people. Yeah. But when we make big recommendations based on a gut feeling, we have a lousy track record. We ignited the opioid crisis doing that, saying opioids were not addictive. That was a dogma. We ignited the peanut allergy epidemic by telling parents to make sure no child 0 through 3 is exposed to peanut butter. And that lack of early exposure created the immune sensitivity that ignited these later significant peanut allergies. And for 15 years, we got that wrong. It was just reversed. The recommendation was just reversed 7 years ago, and many people not even aware that it's been reversed. You want to introduce these things early, little peanut butter, little milk, eggs, as soon as the kid can eat. So I think one of the biggest tragedies of medical dogma that is still a tragedy to this day, a modern day scandal, is the underuse of hormone replacement therapy in women who have gone through menopause within the last 10 years. A woman who starts replacing their body's natural estrogen or estrogen plus progesterone, what we call hormone replacement therapy, or at the time of menopause, when you start hormone replacement therapy, women feel better. They live longer. There are short-term benefits of alleviating most or many of the symptoms of menopause, which 80% of women experience. But beyond that, beyond just feeling better and clearing up the brain fog and weight gain and mood swings and the other aspects of menopausal symptoms, there are long-term benefits because the estrogen oxidizes, makes nitric oxide, keeps the blood vessels soft and dilated, and does something to the nerves. It preserves and maintains nerve function. And so long-term, taking hormone replacement therapy starting within several years of menopause women have 50 to 60% less cognitive decline. The risk of Alzheimer's goes down by 35% in one study. Women have half the rate of heart attacks. That's the number one cause of death in women. Women on average live 3.5 years longer. If they fall, they're far less likely to need surgery for a bone fracture because their bones are stronger on hormone replacement therapy. There's probably no medication that has improved the health of a population more than hormone replacement therapy, arguably with the exception of antibiotics. However, most doctors do not recommend it because of a medical dogma that was introduced 22 years ago by an NIH scientist who held a press conference announcing that a study he had conducted showed that hormone replacement therapy causes breast cancer. Now, when you look at the actual data, and I did the investigative journalism in the book Blind Spots, the study did not support that claim. The data, there was no increased risk of breast cancer or breast cancer mortality that was statistically significant. But he had gone on record beforehand, basically saying we have to stop this bandwagon of people taking hormone therapy. He had already made up his mind, it sounded like, before the study was released. But because he didn't release his data at the time of his press conference, the media ran with the story. Doctors assumed that because it's a large study conducted by the NIH, that it was true. And this dogma is still prevalent to this day. To this day, 80% of physicians will tell you they don't prescribe it because of the fear of breast cancer. And there's an incredible backstory of the infighting that went on before the announcement. Many doctors were very concerned about this being a fraudulent and misleading announcement. So I think people need to know the truth. And this is a good example, something that applies to every family in America. Tragically, 50 million women, including my mother, were denied hormone therapy when they should have started it because of this dogma. So that's one example of medical dogma that took on a life of its own and is still very much an issue to this day.
Yeah, I can speak being, a woman in her 50s about my friends and other women that this is not widely known. And it only kind of makes me wonder, how does this information then get changed? How do you change the dogma? How do we change this particular example?
Yeah. Well, take a look at the food pyramid. For 60 years, we got that wrong, and we're still working to change it. We know it's not the natural fats in foods. We know it's the refined carbohydrates and the processed flour and the added sugar and the, maybe even the seed oils. We're learning more about that. So how do we change that? Again, this is the psychology of groupthink. The cognitive dissonance that Dr. Leon Festinger described in the 60s, that we hold on to what we believe first. And that's a battle, right? We all have these tendencies to hold on to what we believe here first and not to believe what's most logical, what makes the most sense. And so we're going to continue to try to educate both doctors and the public. And I think when people hear the story, I love to tell stories. You've heard me speak before. And so if you just tell someone a fact, they're not going to remember it. But if you tell them the story of the backfighting that went on before an announcement, then they can become intrigued and they will remember that fact forever.
Yeah, I think that's exactly right, because that's already what's sticking in my head. And I'm going to go talk to all my girlfriends after this. So let's shift to employers and purchasers of healthcare. That is the BHC membership and our focus. And maybe talk about, what they should be concerned about related to blind spots, like what's at stake for their organization, their employees, or any examples you can give of employer-driven initiatives that successfully navigate these blind spots. We're always trying to give employers some guidance on what to do about things like this.
Mm-hmm. Well, one of the reasons I love what BHC is doing, and so many employers around the country, is employer-sponsored healthcare is the most exciting part of our entire healthcare system. It is challenging deeply held assumptions. It is redesigning ways of doing things. It's recognizing that our fee-for-service business model is not in the best interest of patients. And as proxy purchasers of healthcare are making big decisions on what they believe is best for the health of their employee population. So that's why many of us that have been interested in public policy and public health and the business of medicine have been very closely intertwined in this employer-sponsored healthcare space. We see the innovation happening. We see entrepreneurs and physicians and health professionals of all kinds come up with new solutions that make sense. And I think right now is a good time to stop and recognize we can fix health insurance. We can fix our business model problems. We can give everybody gold-plated health insurance. We can have whatever health reform people fantasize of. But if we continue to issue bad health recommendations and give people the wrong information on health and ignore these giant blind spots of medicine of how our food supply is being affected, then we'll continue to struggle and squander billions of dollars. So we've got to pause and actually take a look at what is good health information. And it turns out that there is very important health information that directly affects the health of everyday Americans that people are not aware that they should be aware about. For example, taking an antibiotic when you don't need it alters the microbiome. New research is coming out, the lining of bacteria in the GI tract. And that lining is important. It's involved in digestion. It trains the immune system. It produces serotonin, which is involved in mood and mental health. There's a connection to the brain and brain health. It makes some of the bacteria make GLP-1, the active ingredient in Ozempic. And farmers have noticed for a long time that when animals take an antibiotic, they are fatter. And research has shown this is true in humans too. So there's incredible new research, and people need to know not to take an antibiotic if they don't need it. Okay, 60% of antibiotics are unnecessary. Same with C-sections. It alters the microbiome. Instead of the baby's gut being formed from bacteria from the birth canal that seed the baby's microbiome, when a baby is born by a C-section, a baby is extracted from a sterile operative field, and what may seed the baby's microbiome are the bacteria that normally live in the hospital. And so we've seen some incredible studies just come out looking at the higher rate of colon cancer in young people. You're familiar with that?
Yeah.
An association between those individuals being born by C-section. This is not fringe research. This is JAMA surgery. And so remember, antibiotics and C-sections save lives, and they need to be done sometimes. But we have a massive overuse problem. We have both problems, underuse and overuse, but by far overuse is dominating the system. Employers have point solutions now. We have one called Global Appropriateness Measures, or it's a group I work with, gameasures.com. And Dr. Will Brune, who runs it, is now giving employers access to a physician C-section rate that you can look up. Primary care clinics are using it for care navigation. You can look up how a spine surgeon performs on appropriateness measures. They've developed hundreds of appropriateness measures for physician profiling and network profiling. There's a group called Visana, which is helping specifically with women's health, partnering with female employees to say, hey, we want to help you in your health journey. We want to help you go through menopause as a partner. We'll talk to you about hormone replacement therapy. They get it. They're up to date on the latest science. And so that's an example of the innovation out there. UMA is partnering, OUMA, partnering with groups that want to provide second opinion services for women during pregnancy. They've got good data that they've reduced NICU utilization maybe the most expensive, high-priced service in all of medicine. So we are seeing some cool innovation right now, and it's living and spawned out of the employer-sponsored healthcare space.
Yep. And I think what I take from that, Marty, and to our members is that BHC can be a resource for this, not only bringing sort of new information and new research to light, but also highlighting some of the solutions that can help employers tackle these issues.
Yeah, it's important to have a good partner to advise on that because there's millions of point solutions. It's hard to tell what's actually going to improve health and what's a gimmick. And so that's where a good consultant and a good partner like BHC can be extremely helpful. I know you and I have talked about solutions for individuals with diabetes and other chronic diseases. Again, the hard part of chronic disease is not just telling people what to do, it's helping them do it.
Right. Marty, this has been great. It's a wonderful preview of our upcoming event with you. The people that come to the event on September 13th are all going to get a copy of your book. So there's another plug to come to the event. But Marty, for those that can't make it, when will the book be released and when can they buy it?
Great. Well, I'm really excited about this book. Thank you for mentioning it, Laurel. It is available wherever books are sold. It's now available for pre-order. And within a matter of days here, it'll be in every bookstore in America. So thanks for mentioning it.
Very exciting. Well, thanks again for your time today, Marty. We truly appreciate your dedication to improving healthcare and holding the health system accountable and providing high quality care for patients. You know, we need more Martys in this world, and just thank you for all the work that you do. And thanks for listening to Be Health Connected, empowering healthy workforces one conversation at a time.
Thank you for listening to the Be Health Connected podcast. For additional episodes or to learn more about employer resources available through the St. Louis Area Business Health Coalition, please visit www.stlbhc.org.